All right, guys, girls, we're going to try something new this time. This will be an instructor-led course. Um, again, let me know what you think about it when it's over with. We can do this more, or we can never, ever, ever do it again. Just depends on what you think about it. So this is pediatric arrest and post-resuscitation care. Pediatric arrest is 2.5 hours of credit and post-resuscitation care for a half an hour. Pediatric cardiac arrest. Um, as you remember, two fingers just below the intermammary or nipple line of an infant, compression rate at 100 to 120 a minute. Compress 1/3 the anterior posterior diameter of the chest, about 1.5 inches. Remember, don't be afraid to hurt the baby. Doing shallow compressions is lethal, and chance of resuscitation on an infant are high. So always make sure you're doing adequate compressions. The minimize interruptions. Compressions combined with ventilations greatly improve infant outcomes. Remember, most of the time when an infant or a small toddler goes into cardiac arrest, it's respiratory in nature. So they've been suffocated, they've choked, or they have severe respiratory illness. So ventilation is key in pediatric arrest. Definition of a child from 1 year of age until the onset of puberty. One or two hands over the lower half of the sternum, whatever you need to appropriately accomplish this. So if you need to use one hand, if you need to use two hands, it's all based on you. As long as you get the depth and the rate, that is key. Push hard and push fast. To rescue or CPR. Fatigue leads to inadequate depth and rate, so monitor one another. Rotate between who's doing compressions and who's doing ventilations. You rotate every 2 minutes. And whoever is doing ventilation should monitor the compressions of the other person to make sure that they're getting adequate rate and depth. Remember, at the 2 minute mark, we switch out. We have a really bad habit of saying, no, I'm good, when in fact you're not. So remember to switch out. Allow complete recoil of the chest between compressions. Don't hover. Don't half release. Remember, with ventilations, just enough air to see the chest rise. What happens when we overventilate? We fill the stomach with air, because what can't go into the lungs is going to go down the esophagus. And once we get the stomach full, it impedes cardiovascular circulation. It puts pressure on the heart, increases intrathoracic pressure, decreases cardiac output, and it causes them to vomit. Two breaths after every 15 compressions. Remember, in pediatrics, it's 15 to 2. Using a BVM, make sure you have the appropriately sized mask. We do carry pediatric and adult BVMs in our bags. The pediatric can be used on an infant. You need to invert the mask. So, gaining an airway. You can use endotracheal tubes for you paramedics out there. Cuffed or uncuffed. On neonates, you always use an uncuffed tube. Compression should not be interrupted during the placement of the advanced airway. Supraglottic airways, we do not carry appropriate sizes for pediatrics. So for us, they're a no, but they do make them down to a size 0. We just do not carry them. Capnography, typically 35 to 45 millimeters of mercury in a normally perfusing patient. Greater than 45 ensures, make sure that you're ventilating properly. 15 to 35, common in cardiac arrest. Less than 10, make sure you're doing good compressions. And remember, when you have a spike in your, wrong button. When you have a spike in your EtCO2 or in your end-tidal CO2, that could mean that you have ROSC, or regains of spontaneous circulation. Vascular access. Don't waste a lot of time obtaining vascular access. IO is the preferred route for infants. Rapid, safe, and I will debate effective with you, but on babies, it's almost the only available route. Intravenous placement can be difficult, especially in the critically ill infants. So IO is the way to go. Use your Braslow tape for determining drug dosages and various other things. It will tell you what size tube you should use. It will give you an estimated weight of the child. Very handy tool. Should have one in your bag if you don't see me. This is not an EMT thing, but you paramedics. Here's all the nifty information. You'll see it tells you drug dosages for a plethora of different drugs, how much fluid you can give, what size tube, what size blade, just a lot of information there. To measure, unfold the tape, red to the head to the heel. So place the red arrow at the top of the head, usually at the top of the forehead. Don't wrap it around their head. And then note what color the heel falls into. Make sure that you put the red marker to their head. And we have a little video that kind of reinforces that.
So as a part of our Gimme 5 initiative this week, we are talking about the do's and don'ts of the Braslow tape. One of the things that we've noticed in our classes is that if you do this one thing wrong, it could mean the difference between your child living or dying. That is such a huge deal. So, in a stressful situation, you need to remember that with the Braslow tape, there is a red side that says measure from this end. That means that red goes to the head of the child and you measure to their heel. So we see that this little one, Kylie, is going to be in the pink zone. Sold about 6 to 7 kilos, is going to get a 3.5 ET tube. Great. In a stressful situation, we get all turned upside down. Sometimes the Braslow tape that we should be practicing with all the time is locked in the cabinet and we don't get to practice like we should. So what do? We accidentally grab the tape. We're like, okay, let's go. This child is on the ground. Let's measure. Red to the head to the heel. Wait, where's the red? Oh no, I didn't even notice that I just measured this child upside down. This child, in my mind, is now in the white zone. Let me tell you, there is a huge difference between an 18-kilo child and a 6-kilo child. Kylie here is 4 months old, not 4 years old. The difference between getting a 5 ET tube and a 3.5 ET tube could mean the difference between an attorney knocking on your door. So, just remember, even in those stressful situations, if you remember nothing else, red to the head to the heel. Measure right, give me 5.
So consider your underlying causes, your H's and T's. Hypoventilation, hypoxia, acidosis, hyper or hypokalemia, hypothermia, hypo or hyperglycemia, poisoning, drug overdose, cardiac tamponade, tension pneumothorax, coronary or pulmonary embolism, and of course, trauma. Toxic levels of drugs can occur even if small amounts are ingested. This is going to be obtained through history. Are the parents drug users? Does the home appear, are there clues? So open your eyes, look around. Remember, Narcan is not going to hurt somebody who does not need it. So feel free to use it if you even suspect anything. Commotio cordis. We have a nice little video that it's about the Damar Hamlin incident from year before last in football, and pay close attention because there's going to be some test questions on this.
On Monday Night Football, Damar Hamlin, he made a tackle on the Bengals wide receiver, T. Higgins. Now, in that event, he took a direct hit to his chest, and then he goes to the ground. He then gets up, he adjusts his face mask of his helmet, and then he visibly goes limp and falls to the ground. Medical staff, they attend to him, and he was initially moving his right arm, but then shortly after that, he went into cardiac arrest. Medical staff immediately start doing CPR, including the use of an AED, an automated external defibrillator. They do that to shock his heart rhythm, back into a normal heart rhythm. So he goes from ventricular fibrillation into a normal heart rhythm, which is most likely normal sinus rhythm. He was transferred to the University of Cincinnati Medical Center for further testing and treatment, and he's currently in critical condition. They also said he's intubated, meaning he has a breathing tube down his throat, which is a standard operating procedure when someone experiences a cardiac arrest. So this way you can control the airway and control the patient's breathing, and because of that, he's also being sedated, so that way he's sleepy and comfortable. Now, there's no single test that can prove or disprove commotio cordis. So in order to make that diagnosis, it's a clinical diagnosis. And what we saw Monday night is exactly what happens when someone experiences commotio cordis. But more on that in a bit. So let's talk about commotio cordis in general, which means agitation of the heart in Latin. It's the medical term for sudden cardiac death, temporary sudden cardiac death, or maybe it's not always temporary, but basically means in that moment the heart dies for at least a little bit, and it's brought about by an anterior precordial blow. So basically right here, it's a blunt and non-penetrating type of blow. So it's not a knife or anything, it's a blunt force to specifically this area of the chest, right where it overlies the heart. The primary arrhythmic event of a sudden death from commotio cordis is that chest blow, which is significant because it does not directly destroy the heart's structural integrity. In other words, the heart itself, the physical structure of the heart, the muscle is fine. It's just the electrical system gets shocked, if you will. It's like a big electromagnetic wave, if you will, that just resets. It's resetting the circuit breaker. Commotio cordis has been listed as one of the most frequent causes of sudden death in young athletes, while the actual prevalence is still unknown because it hasn't been studied that much. The National Commotio Cordis Registry was actually developed in the United States in the middle of the 1990s. More than 200 confirmed cases of commotio cordis have been documented since that registry was established. The registry has produced some noteworthy results. So, for example, young people are most frequently affected. The average age of the registry, they were 15 years old. Only 9% of recorded cases were people over the age of 25. 95% of incidents that have been reported were male. So 9.5 out of 10 are male. 75% of the incidents have happened during sporting competition, 50% during competitive sports, and 25% during recreational sports. The majority of incidents have been associated with games using blunt projectiles and/or a higher physical contact. So baseball, lacrosse, hockey, and yes, football. There's several crucial factors, including the timing of the hit during the cardiac cycle, also the position of the impact, and even the velocity of the impact. They all have an impact on the risk of commotio cordis in experimental animals. The timing of chest wall impact within the cardiac cycle appears to be the most crucial factor in the development of ventricular fibrillation in cases with commotio cordis. There's a 20 to 40 milliseconds, so there's 1,000 milliseconds in 1 second. There's a 20 to 40 millisecond window of when there's the upslope of the T wave on that EKG where there's that ventricular repolarization. That's the only time frame during which this can result. So in other words, right in that instance of when the ventricles are about to relax, which is right after the heart pumps that blood to the body, it's that very instant in that cardiac cycle of when commotio cordis occurs. So in other words, commotio cordis can only happen if there's a significant enough force to the area of the chest in that specific moment of the cardiac cycle. And the chances of a direct hit to the chest during this exact moment in the cycle is actually very, very small from a statistical standpoint. Although there isn't a known amount of chest trauma that causes commotio cordis, the projectile's velocity at impact seems to be significant. Now, according to an experimental model, the incidence of ventricular fibrillation rises to 70% as projectile velocity reaches 40 miles per hour. But at collision speeds beyond 40 miles per hour, structural integrity such as myocardial rupture, which is tearing of the heart muscle, and cardiac contusion, which is bruising of the heart muscle, those are more common while the likelihood of ventricular fibrillation goes down. So VFib, which is ventricular fibrillation, it's more likely to be caused by harder objects. So smaller diameter spheres are more likely to result in VFib than flat objects, at least in the experimental model. So in other words, a tennis ball isn't going to have the same kind of results with commotio cordis as would a baseball or lacrosse. VFib in commotio cordis, it appears to be induced by increased ventricular repolarization dispersion brought about by that blow. So the chest impact, it probably activates the ATP-sensitive potassium channel, which aids in the onset of VFib. Now, due to a variety of reasons, younger people are more prone to getting commotio cordis. The most typical occurrence happens in sports with a dense projectile, baseball, lacrosse ball, or hockey puck, resulting in that specific area of blunt force trauma in that specific area of the chest. Although the reported types of chest strikes producing commotio cordis have varied, this is definitely the most typical scenario. But larger spheres and non-spherical objects can still do it, and it has happened in football. How do we make the diagnosis? The clinical scenario, which involves a witnessed blunt chest impact followed by almost instantaneous collapse, the available EKG data showing that ventricular fibrillation, and the absence of structural heart disease or absence of myocardial trauma on the imaging studies, whether that's on the ultrasound of the heart, which is the echocardiogram, or on the CAT scan or the MRI of the heart. So if all those studies check out okay, and you get the exact clinical story of what I just described, that's how you make the clinical diagnosis of commotio cordis. With that said, you still want to rule out other possibilities. That's why a thorough examination needs to be done with different tests in all commotio cordis survivors. You want to check for structural heart disease, in particular arrhythmogenic right ventricular dysplasia, hypertrophic cardiomyopathy, anomalous coronary arteries, and you want to look for Brugada syndrome and a couple other things. Although a blunt chest blow is necessary to cause ventricular arrhythmias in commotio cordis patients, any structural harm done to the body from this hit is limited to the chest wall. So this is a crucial distinction between studying cardiac death from commotio cordis and then more serious damage that could result in a cardiac contusion or myocardial rupture, both of which have significant mortality rates. Commotio cordis, it's a primarily electrical event, and in the majority of sufferers, ventricular fibrillation is the first reported arrhythmia. With no recorded survival in the first 25 patients in the National Commotio Cordis Registry, survival rates in commotio cordis have historically been very low. But more recent data reveal that survival is increasing because 58% of reported patients between 2006 and 2012 have survived, and thanks in large part to having AEDs and medical staff attending these athletic events. So the earlier recognition with EMS, emergency medical services, the increased amount of CPR training performed by bystanders, earlier defibrillation, they all play a role in survival and prognosis. Surprisingly, both in the clinical setting and in the laboratory animal research, it has not been demonstrated that commercially available chest wall protectors can successfully prevent commotio cordis. The National Commotio Cordis Registry received reports of several of these victims who were wearing protective gear at the time of their incident. Can someone who survives this actually return to playing that same sport? Commotio cordis is a rare occurrence, probably because so many precise mechanical factors must be achieved in order for this to happen. Timing, location, velocity of impact. There's a few animals in the experimental models that were specifically vulnerable to that chest blow development of getting VFib. With that said, there's still an unknown whether there's an individual predisposition to getting commotio cordis. So at the end of the day, even though the chances of it happening again are very, very small, you certainly can't blame someone for not wanting to return to that sport. There's actually one case of a guy who survived commotio cordis on 2 separate occasions. As of right now, according to the most recent 2015 American Heart Association, American College of Cardiology consensus statement regarding the eligibility and disqualification recommendations for competitive athletes, for those who survive commotio cordis, they can only return to the sport if they go through all of the appropriate cardiac testing and are found to have no cardiac pathology. It's a great sign that they were able to do immediate CPR because that's the biggest factor in his prognosis. So I'm very hopeful and optimistic about his prognosis, and of course, thoughts and prayers to him and his family.
So, commotio cordis is a consideration. Also, long QT AHA channelopathy, which would be a previously undiagnosed condition. Just know that children do not normally go into cardiac arrest unless there is some significant event. They don't do cheeseburgers, they don't have plaque buildup, that sort of stuff. Most of them don't smoke. So that ends the pediatric cardiac arrest portion of this lesson. And I'm going to take a short break. You won't actually realize that break, but I'm going to take a short break and then I'll come back and finish. So, post-resuscitation care in adult and pediatric patients. This is good for a half hour of continuing education. Recognition of the return of spontaneous circulation. You continue CPR until signs of life are observed. Sudden increase in end-tidal, presence of a pulse after organized rhythm. Patient is breathing or moving. So if you're using an AED and you don't have end-tidal, basically it's somebody moving or breathing on their own or someone who has a discernible pulse. When do we check a pulse? As you know, we only do pulse checks during our analyze phase for the AED. So be sure that you only check during the analyze cycle, which would be, or after the analyze, which would be every 2 minutes. So your AED is going to It's going to tell you to stop CPR, don't touch the patient, analyzing. It will analyze for approximately 10 to 15 seconds, and then it will tell you no shock advised or shock advised charging. And something we have observed is certain AEDs detect compressions while they're charging, and they will dump the charge and not shock the patient. So what we have been teaching, which is to do compressions while the AED is charging, is going to have to be rethought, because it will pick up the motion, it will think it has an organized rhythm, and it will stop charging and dump the shock. So while it's charging, you're going to have to stay off the chest. This is a little video on post-resuscitation care. Enjoy.
Welcome to the lesson on post-cardiac arrest care. In this video, we'll discuss what to do after cardiac arrest care. If an individual has a return of spontaneous circulation or ROSC, start post-cardiac arrest care immediately. The initial BLS and ACLS processes are meant to save an individual's life, while post-cardiac arrest care is meant to optimize ventilation and circulation, preserve heart and brain tissue and function, and maintain recommended blood glucose levels. Consider blood pressure support in any individual with systolic blood pressure less than 90 millimeters of mercury or mean arterial pressure, or MAP, less than 65. Unless contraindicated, 1 to 2 liters of IV saline or lactated ringers is the first intervention. When blood pressure is very low, consider vasopressors, commonly referred to as pressors. Epinephrine is the pressor of choice for individuals who are not in cardiac arrest. Dopamine, phenylephrine, and methoxamine are alternatives to epinephrine. Norepinephrine is generally reserved for severe hypotension or as a last-line agent. Titrate the infusion rate to maintain the desired blood pressure. Hypothermia is the only documented intervention that improves and/or enhances brain recovery after cardiac arrest. It can be performed in unresponsive individuals, that is, comatose, and should be continued for at least 24 hours. The goal of induced hypothermia is to maintain a core body temperature between 89.6 and 96.8 degrees Fahrenheit, that is, 32 to 36 degrees Celsius. Device manufacturers have developed several innovative technologies that improve the ability to affect and manage hypothermia in the post-arrest individual. Hypothermia should be induced and monitored by trained professionals. Induced hypothermia should not affect the decision to perform percutaneous coronary intervention, or PCI, because concurrent PCI and hypothermia are reported to be feasible and safe. For adult immediate post-cardiac arrest care algorithm, please refer to Figure 30 in your corresponding ACLS manual. This concludes our lesson on post-cardiac arrest care. Next.
So, maintain an SpO2 of greater than or equal to 94%. Once your patient's SpO2 is 94%, more oxygen is not necessarily better. Avoid excessive ventilation. It reduces cardiac output and decreases cerebral blood flow. End tidal should be between 35 and 45 millimeters of mercury. Regulate your ventilatory rate and depth to achieve that goal. Hemodynamic instability in the cardiac arrest patient. Monitor vital signs, ensure vascular access. For hypotension, you would immediately go to the fluid bolus. If that does not work, then you may want to use vasopressors via IV infusion to maintain your blood pressure of 90 or greater systolically. Epi, dopamine, dobutamine, norepinephrine. So, creating an epi drip. You put 1 milligram of 1 to 1,000 in a 500 bag and give a continuous infusion. Initial adult dose is 1 microgram per minute, titrated to the desired hemodynamic response, 2 to 10 micrograms per minute. Using a 60 drop set, you would give 120 drops per minute for 1 microgram a minute. Further simplifying that, 2 drops per second, 4 to 20 drops is 2 to 10 micrograms a minute. Post-resuscitation care arrhythmias. Treat cardiac arrhythmias as required per your protocol. Don't administer antiarrhythmics prophylactically. In other words, don't load them up with a bunch of drugs just in case. Identify the potential cause of the cardiac arrest. Get a 12 lead. If you got evidence of a myocardial infarction, you may want to take them to a different facility. Consider and manage reversible causes. Now we're going to watch a video on targeted temperature management. This one is a wee bit longer.
Let's talk about targeted temperature management, TTM, after cardiac arrest. First, we will review indications for TTM after cardiac arrest with ROSC. Then, we will review the 3 phases of TTM. In doing so, we will describe the results of the landmark TTM trial, and finally, we will identify potential complications of TTM. First, let's review indications for TTM. All patients with a Glasgow Coma scale of less than 8 after ROSC should receive targeted temperature management. Essentially, if the patient is not showing purposeful movement and/or unresponsive to verbal commands, or could reasonably be considered comatose, they should be considered for TTM. Does the arrest rhythm matter? While trials historically included a higher proportion of patients post-shockable rhythm arrest, meaning ventricular fibrillation and ventricular tachycardia, we now have data demonstrating improved outcomes with TTM after non-shockable rhythm arrest, PEA and asystole. The Hyperion trial from 2019 demonstrated improved survival with a favorable neurologic outcome at 90 days with TTM at 33 degrees after arrest with a non-shockable rhythm, 10.2% versus 5.7%. Therefore, the answer is no. Post-arrest patients with shockable and non-shockable rhythms should receive TTM. Does arrest location matter? Again, no. Both out-of-hospital and in-hospital arrest should be considered for TTM if ROSC is obtained. Note, hemodynamic instability is not a contraindication to TTM as long as the patient is on stable doses of vasopressors and inotropes. Our ultimate goal with targeted temperature management is to prevent or decrease post-cardiac arrest brain injury from hypoxia and ischemia. In most clinical trials, this is defined as a favorable neurologic outcome on either the Cerebral Performance Category, CPC, or the Modified Rankin Scale. Favorable by both metrics typically means the ability to live independently with minimal assistance. Does TTM accomplish this goal? Yes. In addition to the previously discussed Hyperion trial, 2 landmark trials from 2002 comparing TTM to normothermia by Bernard et al. And the Hypothermia After Cardiac Arrest study group demonstrated improved outcomes with TTM compared to normothermia, 49% versus 26% by Bernard et al., and 55% versus 39% by the HACA study group. This equates to a number needed to treat of 6 to 7 to prevent 1 unfavorable neurologic outcome or death. After the decision is made to initiate TTM, the patient will move through 3 phases: induction or cooling, maintenance, and rewarming. First, let's discuss the induction phase. The patient should be cooled to the goal temperature as rapidly as possible. Of note, after cardiac arrest and ROSC, many patients will present with a temperature less than 36 degrees Celsius due to mixing of cool peripheral blood with warmer core blood. There are 2 major methods for cooling: external or surface cooling, and intravascular. In our hospital system, the external cooling system is also referred to by the brand name Arctic Sun. The intravascular cooling system may be referred to by the manufacturer title Zoll. External cooling devices typically utilize gel pads, while intravascular devices infuse cold fluids in a closed-loop system. The intravascular device typically has 3 additional lumens that can be utilized for other infusions if needed. Both devices are connected to a terminal that provides continuous temperature feedback to achieve the set target temperature. How do these 2 methods differ? In an analysis of the TTH-48 trial, intravascular cooling devices were associated with a shorter time to target temperature, 2.2 versus 4.2 hours, as well as decreased temperature variability and rewarming rate. There was no difference in mortality or neurologic outcomes. After induction, we enter the maintenance phase. What should our target temperature be, and how long should we keep patients at that temperature? To answer this question, let's review the landmark TTM trial by Nielsen et al. From 2013. The TTM trial was a large multi-center RCT across 36 ICUs in Europe and Australia, comparing TTM at 33 degrees versus 36 degrees Celsius. In the TTM trial protocol, patients were cooled to the target temperature, maintained at target temperature for 28 hours, and then gradually rewarmed to 37 degrees Celsius in 0.5 degrees Celsius increments, with the goal of maintaining a temperature less than 37.5 for at least 72 hours. Main inclusion criteria were GCS less than 8 after out-of-hospital cardiac arrest with greater than 20 minutes of spontaneous circulation after ROSC. What did these arrests look like? 90% were witnessed, 73% received bystander CPR, with a median time of 1 minute until BLS, 9 to 10 minutes until ACLS, and 25 minutes until ROSC. Approximately 80% were shockable rhythms. At the end of the trial, an approximate 3-year period, there was no significant difference in mortality or poor neurologic function at 180 days between the 33 and 36 degree groups. There was no difference in rates of shivering, fever, or adverse outcomes between groups, with the exception of slightly more hypokalemia in the 33 degree group. The authors concluded that TTM at 33 degrees does not confer additional benefit compared to 36 degrees. Next, the TTH-48 trial compared TTM at 33 degrees for 48 versus 24 hours. There was no difference in favorable neurologic outcomes at 6 months, with a higher rate of adverse events and longer ICU length of stay in the 48-hour group. The decision to target 33 or 36 degrees is institution dependent. Why might 33 degrees Celsius be preferred? A retrospective cohort study from 2012 assessing 1,200 cardiac arrest patients over an 18-year period found a maximum benefit of TTM at 33 degrees with respect to favorable neurologic outcome and survival in patients with no flow time, or time from collapse to initiation of CPR, of greater than 8 minutes. Notably, this finding was not replicated in a post-hoc analysis of the TTM trial. To recap, patients should be maintained at the target temperature for 24 hours, with some evidence to indicate that 33 degrees Celsius may be preferred for patients with longer no-flow times. What complications of TTM should we be aware of? Shivering is the most common human response to hypothermia and slows the rate of cooling. First line to control shivering is adequate analgesia and sedation. Fentanyl is a first-line agent for analgesia. Sedation can be achieved with propofol, dexmedetomidine, or midazolam. If unable to control shivering with sedative and analgesic infusions, neuromuscular blockade can be utilized. Adjunctive agents include acetaminophen and buspirone. Arrhythmia is also common. AFib occurred in 26 to 28% of patients in the TTM trial, VT occurred in 15 to 18%, and bradycardia in 5 to 6% of patients. Hypothermia causes a cold-induced diuresis, which can lead to hypovolemia as well as numerous electrolyte abnormalities, including hypokalemia, hypomagnesemia, and hypocalcemia. Hypothermia decreases insulin sensitivity and secretion, leading to hyperglycemia. Control of hyperglycemia may require initiation of an insulin infusion. Hypothermia impairs coagulation and platelet function and increases the risk of bleeding. Coagulopathy and/or active bleeding may be a contraindication to TTM, and risk versus benefit must be considered in these situations. Finally, hypothermia impairs immune system function and increases the risk of infection. Approximately 50% of patients in the TTM trial developed pneumonia. A 2019 placebo-controlled RCT demonstrated that a 2-day course of IV amoxicillin clavulanate after cardiac arrest decrease the incidence of early ventilator-associated pneumonia, defined as the first 7 days of hospitalization. IV ampicillin sulbactam, or another similar antibiotic, can be utilized. After the maintenance period, the patient is rewarmed to 36 to 37 degrees Celsius. Rewarming should occur at a rate of 0.2 to 0.5 degrees Celsius per hour. It is critical during the rewarming period to avoid rebound fever. Therefore, patients should be locked in at a temperature between 36 to 37 degrees utilizing the feedback system of the external or intravascular cooling device. Neurologic prognostication with the assistance of a neurologist or neurocritical care specialist can typically begin as early as 72 hours after the arrest. Prognostication includes consideration of the clinical exam, including motor response to pain, pupillary and corneal reflexes, imaging, including CT, MRI, and EEG, and biomarkers, including neuron-specific enolase, a protein released from injured neurons. In this video, we reviewed indications for targeted temperature management after cardiac arrest with ROSC, and identified that all comatose patients should be considered for TTM regardless of etiology or location of arrest. We then reviewed the 3 phases of TTM: induction, maintenance, and rewarming, during which we described the results of the landmark TTM trial, which found no difference in outcome between TTM at 33 versus 36 degrees. Finally, we reviewed potential complications of TTM, including shivering, arrhythmia, cold-induced diuresis, hyperglycemia, bleeding, and increased risk of infection. Thank you for watching.
So, targeted temperature management can increase favorable outcomes in ROSC patients. Lowering and controlling core temperature slows cellular metabolism and reduces cell damage and death. It's not typically something that we do in the field, but we need to have it in the back of our minds. For example, taking the patient to a facility that is capable of doing targeted temperature management. Temperature measurement is in-hospital consideration. Axillary, tympanic, temporal artery, and oral measurement may be unreliable. Measures of core temperature. Foley catheters or esophageal probes are preferred. Out of hospital patients with ROS, commonly the temperature is lowered using rapid infusion of cold intravenous fluids, which has been demonstrated to have adverse effects. Most deaths following ROSC occur within the first 24 hours. Transport to the most appropriate facility. Maybe a STEMI PCI center, cardiac center, or a therapeutic hypothermia center. All right, and that is the end of this lesson. Obviously, you can't do skills remotely, but there will be a link posted along with this video for a written evaluation. It'll be a Google quiz. Please complete the quiz, and we'll get you down for your credit.